Have you ever had a colonoscopy and your doctor says, "Good news, no cancer"? Oh, and you have diverticulosis. And you're sitting there like, divertic what? Before we dive in, comment if you've ever had a colonoscopy, and if so, how did it go? Now, diverticulosis means small pouches, called diverticula, have formed in the wall of your colon, most commonly in the sigmoid colon. And here's the wild part. Most people don't feel anything at all. They find out because they finally got that colonoscopy, or because they had one for symptoms. So today, we're doing something your average appointment often doesn't do. We're answering the question, why did I get diverticulosis in the first place? And if you stay with me, I'll give you a simple root cause framework, because this is one of those diagnoses that can feel like a dead end, but it's actually a signpost. Very quick colonoscopy reminder, because I can't be your doctor on YouTube, but I can be your annoying friend with a stethoscope. If you're at average risk for colon cancer, major guidelines recommend starting screening at age 45, continuing regularly through about 75, and then making an individualized decision from 76 to 85 based on your health and prior screening. And you can screen with stool tests, Cologuard, or visual exams like a colonoscopy. But there's even a new blood test called Shield, not widely available yet, but should be in the very near future. How cool is that to have a blood test for colon screening? Talk with your clinician about what fits you. And please, 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 don't let fear steal prevention, because fear is simply false evidence appearing real. Okay, back to diverticulosis. Important distinction. Diverticulosis is the pouches. Diverticulitis is when one of those pouches gets inflamed and sometimes infected. And symptoms include pain, fever, feeling awful, and occasionally complications. They're related but not identical twins. So what causes the pouches? Here's the simplest explanation. Pressure plus weak points plus time. Your colon wall has natural weak spots where blood vessels pass through. Over years, if pressure inside the colon gets repeatedly high, especially in the sigmoid colon, small pockets can push outward through those weak areas. That's diverticulosis. Now let's talk about why pressure goes up. A big driver is constipation and straining. Harder stools can make the colon squeeze harder, increasing segmental pressure. Over time, that repetitive pressure is like bending a paperclip again and again. Eventually, something gives. But here's where root cause medicine gets interesting. It's not only about stool bulk. Diverticular disease is also linked with changes in motility, neuromuscular function, and connective tissue remodeling as we age. Translation? The plumbing and the pipe wall both change with time. And now we get to an important point, inflammation. Diverticulosis itself isn't always an inflammation diagnosis the way diverticulitis is. But chronic low-grade inflammation and microbiome changes can absolutely shape the terrain. How the colon wall repairs, how your immune system reacts, and how likely those pouches are to become symptomatic. And I want you to hear this clearly. Your gut does not live in isolation from the rest of your body. If someone is dealing with metabolic dysfunction, high insulin, visceral fat, fatty liver, prediabetes, there's often a chronic inflammatory background. That doesn't mean diverticulosis is caused by sugar in a simplistic way, but it does mean that whole body inflammation may create conditions where tissues don't repair as cleanly. Motility is altered, and flare-ups are more likely. That's why I want my patients and you to stop seeing diverticulosis as a random surprise and start seeing it as a potential metabolic signal. Now let's address the classic advice most people hear. That's to avoid nuts, seeds, and popcorn. I personally don't eat those things. Well, because I'm a carnivore. But many of my patients aren't, and that advice is old school. The idea was that small pieces would get stuck in the pouch and trigger diverticulitis. But large studies and guideline discussions have not found that nuts, corn, and popcorn increase diverticulitis risk. In fact, in one major long-term study, higher intake of nuts and popcorn were associated with a lower risk of diverticulitis. So no, your colon is not being attacked by a rogue sesame seed. Now we get to the elephant in the colonoscopy room, fiber. You've probably heard diverticulosis happens because you don't eat enough fiber. Here's the nuance. A lot of people do great without added fiber. I'm a carnivore. I don't need fiber to be regular. And plenty of keto and carnivore folks are the same. So I don't want anyone walking away thinking, oh no, I have diverticulosis. I must start eating bowls of bran. Because for many people, that's not the fix. That's just bloating with confidence. What matters more is this: pressure and irritation in the colon. If your stools are hard, dry, or you're straining a lot, pressure goes up. And over time, that pressure can contribute to those little pouches forming. So here's my practical root cause approach. If you're keto, carnivore, and doing well, regular bowel movements, no straining, no pain, you don't need to chase fiber. Focus on the fundamentals: hydration, electrolytes, enough dietary fat, and daily movement. And if you're constipated, or you're doing keto-ish with a bunch of processed low-carb foods, sugar alcohols, protein bars, seed oils, or not enough fluids, then fiber may help some people as a tool. Not because fiber is magical, but because it can improve stool softness and consistency in certain situations. And I'll say it like this: fiber is optional for many humans, but constipation isn't optional for your colon. I'll be honest, in my clinical practice, some patients do better on fiber. But for most of us, the goal is not more fiber. The goal is less straining, less pressure, and less inflammation. How you get there depends on what you eat and how your gut responds. And just to keep the internet peaceful for 5 minutes, if fiber works for you, great. If you thrive without it, also great. The colon cares more about the end result than the ideology. Now, what should you do if you've been told you have diverticulosis? Here's the root cause prescription. Number 1, reduce inflammatory inputs. That means backing away from ultra-processed foods, refined carbs, and added sugars, especially if you're dealing with insulin resistance. Rather you eat carnivore, keto, low carb, Mediterranean, or something else, make it real food, make it clean, and make it sustainable. Number 2, support regularity without obsession. Again, the issue is not fiber righteousness, it's still consistency and pressure. For many keto carnivore folks, what they need to focus on is hydration plus electrolytes plus enough fat plus movement, which solves it. For some people, magnesium support can help. And for some people, a small amount of fiber can help. But I would optimize the other options before leaning into fiber. And the goal is simple: no daily straining. Number 3, move your body. Physical activity is linked with lower diverticulitis risk, and movement helps motility. Your colon is basically a lazy coworker. It does better when you take it for a walk. Number 4, watch common accelerants. Smoking and central obesity show up repeatedly as risk factors for diverticulitis. And frequent NSAID use like ibuprofen and naproxen has been associated with higher risk in guideline discussions. I'm not saying never use them. I'm saying don't live on them. If you're taking NSAIDs regularly, ask, what inflammation am I ignoring? Now, quick mid-video check-in. If this is connecting dots for you, hit like and subscribe, because this channel is about turning mystery diagnoses into understandable mechanisms and then into action. So when should someone worry? If you have known diverticulosis and you develop new severe abdominal pain, often left lower abdomen, fever, chills, persistent vomiting, or blood in the stool, you need evaluation. Diverticulitis can be mild, but it can also become complicated. Don't tough guy your way through something that needs treatment. Let's land this. Diverticulosis is common and often found during screening colonoscopy. Conventional advice is often short and sometimes outdated. But the deeper story is pressure, tissue changes over time, motility, microbiome terrain, and the inflammatory metabolic environment that can increase risk of symptoms and flare-ups. Your colon is not separate from your metabolism. So if you've been told you have diverticulosis, don't just avoid popcorn and call it a day. Pick one next step this week. Take a 10-minute walk after meals. Tighten up your food quality, especially if the keto in your life comes in a shiny wrapper. Dial hydration and electrolytes in. And if you're 45 or older and overdue, get your screening plan in motion. And if you want more videos like this, where we connect the dots between everyday diagnoses and metabolic root causes, check the playlist and the description. I'll put the studies and resources there. And now I want to hear from you. If you were told you have diverticulosis, what did your doctor tell you to do? Or did anyone explain the why? Thank you for coming to this video, and I'll see you in the next one.